morning. So welcome to Dermatome assessment. So let me give you a little bit of definition of dermatome. So dermatomes are the area of the skin that signals or sends signals to the brain through the spinal nerves, okay? So these signals are rise to sensation involving your temperature, pressure, and pain. So what are the tools that we use to check dermatome in our unit? Do you have any idea? So first one is the paper clip. The paper clip is popular because it's very, it's just there on the table, it's secretary, and you can assess the pain by assessing or asking the patient which one is dull and sharp, okay? So another tool that we use is the ice packs. The ice packs, they can distinguish cold, so that's another thing that we can use. And another one is the very handy one is the alcohol swab, because you can just put it in your pocket and check it. And then another one, if there's no, paper clips and then alcohol swab, you can use pinching, okay? So pinching the patient is another tool of assessing your dermatome. So as you can see, you should have this at the back of your ID. If you don't have this, you can ask April. They can give you a handy one that would guide you for your dermatome. So this is the schematic demarcation of dermatomes. So we start from C2 to C8 because there's no dermatome for C1, okay? And so C cervical has 8 cervical nerves, and we have 12 thoracic, 5 lumbar, and 5 sacral. And so the last nerve that we assess or check is the sacral. So how do we check that? We check that by asking the patient to squeeze the glute, okay? You don't stick your finger there and squeeze the glute, but what you can do is ask the patient. It's more of subjective. So you just ask the patient, can you squeeze your glute now? Then if they can, then you are already at S5, okay? And then usually from OR to PACU, they already start their dermatome at thoracic. But here I kind of highlighted T12. Why it's important? Because that's one of our criteria where we can move patient from phase 1 to phase 2. It's the thoracic 12. So thoracic 12 is just above your symphysis pubis, and it kind of go to your groin or inguinal areas, okay? That's one of the criteria. Another criteria when you move your patient from phase 1 to phase 2 is stable blood pressure. When you say stable blood pressure, you should be slowly putting the patient's head position in sitting position, at least 3 cycles of stable blood pressure before you can really move that patient. Because the common side effects or complication for spinal anesthesia is post-procedural hypotension. And if they complain of headache, that's actually late already. So it means that they already suffer from hypovolemic, okay? So that's another criteria. And sometimes the doctor wants to check the bladder because the patient has been there for so long. They don't have that sensation, but you feel the pressure, and they will probably report, I think I feel like I need to pee. So they have that kind of little sensation. So you want to bladder check them. If it's more than, over 200, then you want to ask the doctor if there's something that you want to be doing the Foley catheter in and out. Then where do you document it? So dermatome can be documented under neurological assessment in your PACU flow sheet. If for some reason you're not showing your dermatome level, you just have to put exceptional and it should populate there. Now say for example, if your dermatome starts at thoracic or T12, you just have to type in thoracic and it should populate T1 to T12, and then you start documenting it from T12, okay, where the sensation was felt. And then for your motor or your CMS, your circulation, sensation, and movement, you also want to check that one. You can ask the patient to lift their bottom if they can, okay, and the legs as well. It has to be bilateral, equal, and then you can do your documentation under musculoskeletal, okay? That's your circulation, sensation, and movement. Now, you have to orient the patient that the movement comes first before the sensation. So you have to make sure, because some patients are getting anxious that, how come I can move but I cannot feel it? So you have to explain it to them. So they can wait, you can ask the patient to wiggle the toes or, move, or they can push or do all those neurological assessment. And then for the criteria, so once your patient is discharged, they say, for example, they went to phase 2, you have to make sure you have a stable blood pressure. PAS score is 12, pain level is accepted on your in level of they can tolerate. and then patient must be evaluated by anesthesia and given a sign out, okay? And then three criteria that we do before they go home, okay? One is ambulation. Number two is they're able to pee, okay? And number three is they have a stable blood pressure, because again, they can develop hypotension with spinal anesthesia. Okay, spinal anesthesia, common surgeries that we have, orthopedic, femur, all these orthopedic procedures that we have, they sometimes put the patient in spinal anesthesia because it's less, complications such as bleeding, less complication for the heart. So most of the patient that has heart problem, they sometimes give spinal anesthesia, depending on, of course, the anesthesiologist. What else? Peripheral nerve block. Do we check dermatome? We don't check dermatome for peripheral nerve block. We only check the circulation of the other leg and the sensation, but dermatome is not checked. Do we need consent for dermatome? Peripheral nerve block. We do need the consent, and we want to verify the correct side and site, okay? It has to be marked by an anesthesiologist, making sure you're doing it right. You have to prepare the room. You have to have your suction, your ambu bags, and everything ready before the procedure. And you have to do timeout with the anesthesiologist. And why making sure that there's your ambu bag and the peripheral nerve block? Because patient could develop toxicity with this, okay? And sometimes the signs and symptoms of toxicity include seizure, and sometimes they go to coma. So we have to have the intralipids or the fat emulsion ready in our cart, just to make sure that, just in case that one happens or that thing happens. Now you need to be checked out 3 times before you can assist the anesthesiologist for your peripheral nerve block, okay? Now there was a question, can I push the plunger while the anesthesiologist is, trying to locate or doing something? Yes, you can, as long as the anesthesiologists are inside the room, okay? They cannot leave the room. And then, of course, you want to make sure you're documented. They can go home while the site is still numb, or, because the intention is to numb it for 24, 36 hours. Questions? Yeah? Okay, that's it for dermatome and peripheral nerve block. Thank you.